Good morning. You're now listening to Kingston Community Radio, airing on FM 92.5 and AM 920 WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Hamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to help bring this program to you. Mail your contributions to Kingston Community Radio, Post Office Box 4364, Kingston, New York, 12402. And for more information or to donate online, visit our website at mykcr.org. Good morning. This is Dan Gatis, and thank you for tuning in, sharing the morning with us, being a part of today's program. It's Monday, November 1st, Rabbit. 46 degrees here in Uptown Kingston, and we'll be right back.
As warm days slip away and the weather gets cooler, most of us will begin restarting our home heating systems. And that's when the threat of carbon monoxide poisoning is most critical. This potentially lethal hazard can occur with any furnace or boiler, so be sure to have yours professionally serviced regularly. Make sure chimneys and exhaust vents are clear, and use carbon monoxide detectors throughout your home. Central Hudson reminds you, your safety matters.
This fall, give us your best shot. Your photo of the Hudson Valley's autumn scenery could be worth $750. Enter Central Hudson's 9th annual Fall Foliage Contest today. If your photo gets the most likes on our Facebook page, you win. Deadline to enter is November 5th. For contest rules and information on how to submit your photo, go to Central Hudson's Facebook page or visit centralhudson.com.
Hi, I'm Ruth Quick from Town of Ulster. I support Kingston Community Radio, and you should too.
And thank you for being with us here at Kingston Community Radio, WGHQ 920 on your AM dial, 92.5 FM, and streaming online at mykcr.org. KCR is talk radio and a call-in show. Our call-in line is 331-9255. And today is a Medical Monday. And a Medical Monday means Dr. Eric Stamberg. And he's here on call.
On call.
And thank you. And good morning, Dr. Stamberg.
All right. Good morning. Welcome to this morning's show. I shall be here until 9 a.m. and Robin Baker will be joining me. Couple non-medical related thoughts coming in, but first of all, it is such a dark morning. You know the old phrase, the darkest before the dawn, but I don't know. It was dark. Did you notice that?
Oh, yes, I did.
I guess you're in town, right? I'm in
the Rondout, and if we see a sunrise, it's because it's coming over Port Ewan.
Okay.
Coming from Port Ewan, and it's darker and darker and darker every morning for the show. For getting up for the show.
Overcast now, but I don't know. Should I make you explain that rabbit reference?
I don't know the origin. All I know is you get good luck if you're the first person in the family or in your circle to say it.
Oh, so you're just racing against your family and
friends. Yeah. It's just a fun game on the first of a month.
John Updike or something, isn't it? Or World According to Garb. Who wrote that book?
Oh, right, sure. I don't know. Yeah.
Well, maybe we'll look that up but it's completely unrelated to anything medical. Anyway, so this morning's show will feature various
except for pregnancy tests.
Well, now you're dating yourself. That's an interesting story in and of itself, the old-fashioned rabbit test. I believe if the rabbit died, you were pregnant.
Yes.
What a weird...
That is such a strange exchange.
I know. Oh, my gosh. Can you imagine that? Poor rabbit's going, it's not my fault. Anyway, so we got various medical topics to discuss today, and I always try to take some of the things that I saw over the past week or so and try to, make it an interesting discussion and kind of boil it down to a lay person's perspectives. So I thought I would talk about something that comes up a lot because a lot of people are diagnosed with it, which is something called diverticulosis. All right, this term is really just kind of thrown around, bandied about, And then there's complications of diverticulosis, something very commonly called diverticulitis. So that's what I had a case of yesterday. And from our perspective, it's bread and butter stuff. It's not really even, it's just routine. But from a patient's point of view, this is something that can make someone quite ill. So the patient is a woman in her early 80s who presented to the emergency room with basically abdominal pain and some diarrhea over the past 2 weeks. And when you asked her, like, what part of the abdomen, was really kind of what they call the left lower quadrant, kind of, the left means your left, not the person facing you. For example, the appendix tends to be in the right lower quadrant, so we're talking the opposite side, which is the left lower quadrant. And to make, to just jump right to the diagnosis, she didn't have a fever, although sometimes patients do. Her white count is elevated. You'll hear that thrown around a lot. My white count was high. And a CAT scan showed the evidence of something called Sigmoid Diverticulitis. So the colon, an amazing part of our body, has kind of 5 parts. The what's called the cecum is that kind of then the cecum is your right lower quadrant, actually right around the appendix. So sometimes abnormalities of the cecum can mimic appendicitis, but that's not what we're talking about right now. And then it has the ascending colon, kind of goes up towards your diaphragm. The transverse colon makes kind of, from your perspective, a left turn, goes across to the left side of your abdomen, and then goes down again. That's a descending colon. And the very end of it is called the sigmoid. It looks like a sigma, basically a Greek letter, and that's where the name comes from. And then it transitions into the rectum and on out. So the sigmoid is the most common location where someone might get this problem. So what exactly does that mean, diverticulosis? Well, diverticulum is kind of like an outpouching. There are other examples of the plural is diverticula. Singular is diverticulum. There's other examples of diverticula throughout our body. But for the sake of discussion, we're going to talk about just like diverticula within the colon. So a lot of people have this. It happens over time. There's a genetic tendency. There is probably, and a lot of evidence to support this, a dietary component. Kind of linked to our collective diets in our American culture. So imagine that your colon, after I just described all these tricks and turns that the colon makes, imagine it's a long tube. And just imagine the basic principles of plumbing. You want that tube to be even and smooth and not have any notches and not have any little outpouchings or whatever. And if anyone's ever seen a pipe burst, that's kind of what happens, right? It kind of bulges, and then right before it bursts, it almost looks like a little balloon. It's kind of interesting. Then it bursts. So that's kind of what a diverticulum of your colon is. It's a little outpouching that can occur over time. And that's sort of why a lot of people are told they have it. Why would they be told they have it even if it's never caused any problems? Well, a lot of us have colon cancer screening, which we should. And one of the most common ways that the colon cancer screening is done is with a colonoscopy. And that will be something that a colonoscopist will see very easily, colonic diverticulum. So you might leave your colonoscopy with that being told that. You don't have any evidence of cancer, but you have diverticulosis. Diverticulosis in and of itself doesn't really cause the symptoms, but there are complications of diverticulosis. So again, imagine that outpouching, and I use the analogy of a pipe that bursts. So
yes, it means that something's caught there too, right?
Things can get stuck in it. Yeah, that kind of builds us up to the diverticulitis discussion. But before we get to that, just kind of other complications of diverticulosis, it can pop. It can cause a perforation, similar to a pipe bursting. It can just kind of swell up and block everything. Again, think of abnormal plumbing and what could possibly go wrong with turbulent flow, and that can cause obstruction. It can also bleed if the area is kind of getting stretched. The blood vessels underneath the surface of the inside of the colon, that's called the mucosa, will get stretched, and blood vessels right underneath it will get revealed and then easily irritated and bleed. That's called a diverticular bleed. It's probably debatably the most common cause of a lower GI bleed. That's probably something worth talking about as well. Anyway, building up the diverticulitis. So you imagine your colon is, again, a lot going on in your colon. And you have things that live there normally. Those are called commensals. Things that, bacteria, your normal gut flora. That's one of the reasons why it's so important to kind of maintain normal gut flora, because it has a big role with your health. But those elements, those commensals, those little bacteria can kind of get in to these outpouchings. And then they kind of set up camp and have a little commensal party. And then they wall itself off and get little, the equivalent of an abscess. When bacteria is kind of walled off, it will cause an abscess. And that's what diverticulitis is. So it gets into those outpouchings, kind of sets up a little camp, little parties, swells, closes off the top of it, and you get what's called a microabscess or diverticulitis. And that's sort of why I thought it was worth mentioning, because that's, common diagnosis. So what's going to happen to this patient? Well, she's okay, and she'll be fine, but she needs a couple days of antibiotics. Because of the severity of her symptoms, she was admitted. You don't always need to admit the patient with diverticulitis. Milder cases can be treated with oral antibiotics, and even more milder cases can probably just be treated with a little tincture of thyme and maybe get better on their own. It's possible that patients with cases that mild don't really even present to the office because they're kind of just waiting it out, and then it kind of gets better over the next 2 or 3 days. But the person with diverticulitis will have typically the part of the colon that has the problem. It can affect any part of the colon, but most commonly that left lower portion called the sigmoid will have pain in that area. Appetite might be diminished. They may or may not have diarrhea. They may or may not have some bleeding rectally. They might have some systemic symptoms, which means fever and chills and shakes. And it can make them quite ill. So the antibiotics are effective, but sometimes the patient needs to be seen by a surgeon and have other treatment. Recurrent cases of diverticulitis will cause so much colonic inflammation that the person might ultimately have to have part of the colon removed. Acutely, they might need to have the colon removed. If it causes an abscess, I talked about a microabscess. If it causes a bigger area, that's called a major abscess. See how simple this stuff is?
I know we don't think in medical terms of inches, but how large would this abscess be if it's a microabscess?
Really micro. I would say around half, probably at its largest, around half of a centimeter.
Half of a centimeter.
So
okay, so that's about an eighth of an inch or something.
I would think of a centimeter like the size of a pea.
Okay, yeah.
So half of that. And they're even smaller than that.
Yes, okay. All right.
But
so
the abscess
it's amazing
can be,
how that can cause so much trouble.
Right. And they're usually multiple. Again, milder cases, if it's just one or two, might just resolve on their own or be easily treated. But a more severe abscess can be quite large. Imagine something the size of maybe a plum.
Golf ball or something.
A golf ball,
Yeah, okay, wow.
even bigger, and an apple, an orange. And an abscess will frequently need to be drained. A surgeon could do that. Sometimes a radiologist kind of also has techniques and tools, because they could use kind of a CAT scan or not an X-ray, but a CAT scan to help get like a needle into the area and drain it that way. So a lot can be done. How do we prevent this? What should you do if you're told you have diverticulosis? And what should you do if you've already had problems with it, including diverticulitis? Well, think of a normal pipe. What's going to keep that pipe nice and healthy? And the answer is to keep things flowing in a steady, non-turbulent manner. So basically, you want to make sure there's enough fiber in your diet to keep your stool kind of even and bulky. And the idea is of a high fiber diet is talked about a lot. Fiber is felt to also be protective against colon cancer, probably just because it kind of keeps things flowing nice and even. You can have your own diet that's high in fiber, but which is great. But I also and the typical American diet does not have enough fiber, which is one of the reasons why we acquired this illness.
Where do you get fiber?
Well, fiber comes from most of your grains and also from a lot of vegetables will have fiber. I remember my grandfather would boy, ahead of his time, would have cereal in the morning and put some what was called a wheat germ, a couple scoops of wheat germ on his cereal. And my brother and I going, ew.
It's great by itself, too.
Yeah, oh, really? Yeah, Grandpa's putting germs on his cereal, We thought that we were going to grossed out by that. But that was fiber. He, again, ahead of his time. Good morning. We're having a discussion about fiber. That's Robin. Good morning, Robin.
Good morning, Robin.
Hello.
All right, so fiber. But I tell a lot of people to take supplemental fiber, which really means as much fiber as you kind of think there is in your diet, you probably need more. If you've already kind of had this problem, you could try to beef up the fiber in your diet. But I do recommend a daily fiber supplement. There's many different brands of that. Metamucil is a brand. Citrusel is a brand. I usually recommend FiberCon. A lot of people kind of don't like the taste or the texture of the fiber. They say it technically does not have taste, but it kind of does have something. Changes the texture of your food or whatever. That makes it difficult for people to want to consume.
Salad's not good enough.
I think it's good as part of a healthy lifestyle, and I think if someone has a high fiber diet over time, they will probably and hopefully never have this problem. But I think once someone has this problem, I think they should, in addition to a high fiber diet, they should also have some supplemental fiber. I usually recommend that.
Well, that's interesting. And also you got to be careful between the balance of carbs and fiber, because a lot of things that have fiber in it are carbohydrates.
Right, grains. Mm-hmm. Right.
What about probiotics?
Probiotics, interesting, and there's some very good evidence that these do play a role. If someone, for example, is on antibiotics, depending upon the type of antibiotic and the length of time they'll need to be on it, a probiotic is probably a good idea to try to keep the normal intestinal stuff there or replenished. But it's interesting because a lot of times the diverticulitis is kind of caused by the normal intestinal stuff. But it is, I think it's good advice to take a probiotic if you're on an antibiotic. And if you wanted to make it a normal part of your intestinal health, the actual evidence probably goes back and forth. But I don't think it hurts to do that if someone chooses to make that part of their. I just don't think it should be a substitute for an overall healthier diet. And I think sometimes that's what happened. You see that with vitamins. I take a vitamin, but it's really, how's the rest of your diet?
Does a regular yogurt have probiotic in it? Just is that what you're looking for? That active component.
It has some element of
component, isn't it?
You're making me. You're
quizzing you.
Yeah.
You love quizzes.
I think another problem that women get when they're on antibiotics is it will lead to yeast infections. Something like yogurt does a pretty good job of preventing that. But yogurt has some things in it that are kind of probiotic. So I don't think it's probably not a bad idea to eat some yogurt. But I think it probably, anecdotally, I think it helps prevent gynecologic complications of antibiotics.
So that can also cause a bladder infection in women, antibiotics?
Well, yeah, it's interesting, okay? 'Cause remember, antibiotics are trying to kill certain bacteria, the bad bacteria, but sometimes when you're killing that, other bacteria might take over, so you could build a resistance as well. Some of these bacteria, in bacteria sense of the word, are rather smart, and they learn how to find their way around the treatment. They develop resistance. So it's one of the big caveats behind trying to be judicious with antibiotic use. So you don't build resistance in the patient, and you don't build resistance in the community. So that's why it's really should always be a pretty big decision to put someone on it. Anyway, so your question was, can being on an antibiotic lead to like a bladder infection? And it can, in the sense that it might select out an organism. Normally the bladder should be sterile, There are some exceptions to that. Women, particularly as they get older, can have some bacteria normally in the bladder. That's called asymptomatic bacteriuria. Basically, it's bacteria in the urine that's not causing any problems. So that's also a good caveat, too, to not even really check the urine unless you have a good reason. So it's case by case and depends on the symptoms. Because in most cases, the asymptomatic bacteriuria should not be treated if it's not causing any symptoms.
A yeast infection, though, is different from a bladder infection.
Right. Yeast infection is fungus. So in addition to kind of maintaining a balance of one bacteria versus another, we're kind of also maintaining a balance of bacteria versus yeast or fungus. Again, very important in the gynecologic system, where if too many antibiotics can eradicate normal bacteria, and then the yeast might take over and cause a yeast infection. You can get fungal infections in your intestine. So it can happen really anywhere.
So the diverticulitis is a bacterial?
It's caused by bacteria. It's a kind of a bacterial complication of diverticulosis. So, the bacteria that is there normally kind of gets into the little spaces and causes a little bit of an abscess and makes someone ill. And so it brings the take home is to a couple things. First of all, to make sure there's enough fiber in your diet. If you've already had complications of diverticulosis, I should say, but see how easy it is to kind of like start flipping these terms back and forth. I do think a fiber supplement in addition to a high fiber diet is a good idea. What should you do if you have a colonoscopy and it shows diverticulosis, or you have a CAT scan for another reason? Maybe someone, has back pain and we're looking for kidney stones. You'll see what's called an incidental finding, a comment of something else. So you might be said, no kidney stones, but it shows you have diverticulosis of your colon. All right. You probably should eat some extra fiber, prevent yourself from getting a problem for that.
Does diverticulitis cause constipation?
Diverticulitis is an acute illness, so it will have symptoms consistent with other acute illnesses like fever, but it will also cause kind of acute pain in the left lower quadrant. I think fiber does many things, and it kind of keeps us going. So whenever someone is having bowel irregularities or constipation, one of the most important things is fiber in the diet. So usually it kind of should be the first stop. There's again, caveats, if someone's constipated because they're on opioid medication, for example, that's the gut has kind of slowed down and even stopped. So to add fiber to that is like kind of, imagine a clogged pipe and just kind of trying to push more, fluid down it. But I guess I'll take that analogy back. It's not really, because it's not a clog when that happens, like from opioids. But adding fiber to the problem, you're just kind of going to bulk it up more. You have to get the gut moving.
Is there a difference between constipation and a blockage in the colon?
Well, constipation is a symptom that has many different causes, but basically the patient is having a difficult time having a bowel movement. And it's uncomfortable. It can be painful. It can be severe.
But it's not necessarily a blockage.
Well, let's use the analogy of the pipe. Imagine if your sink is now clogged. What's clogging it up? A bunch of hair or whatever. There might be something there that needs to come out of the way. People who have tendency towards hard stool might have it might just kind of get stuck there. Very common in elderly people. I had a case a couple weeks ago where the man got admitted for being impacted for a treatment of it. He was very uncomfortable, and an elderly man was also kind of, any illness can affect his cognition, so it was making him very agitated. So we treated it.
And just remove the blockage.
But you kind of do, you got different techniques. You could go from below or you can go from above. Usually if it's that bad, you kind of want to go from below, which is with an enema. But there's other things you can do to try to get the gut moving. And And then the most important thing is when and if this happens, to really try to prevent it from happening again. We use the term bowel regimen. Someone should be on a bowel regimen, or else it is going to happen again.
Drinking lots of water, important.
Yes. Just, again, think about it. Water keeps things flowing. I'm sure there's more complexities to that explanation, but on a common sense level, it makes sense. You agree?
Yeah.
Yeah. Again, there could be complications of diverticulitis and diverticulosis. A person might develop a full abscess, might get quite ill from just having diverticulitis. The diverticulosis can bleed. It can rupture or perforate. Sometimes it can just kind of swell and cause its own obstruction. Imagine just inflammation. And I don't know. I think did I exhaust that subject?
So you mean the diverticulitis is the obstruction itself? It's not stool?
No, but so diverticulitis, and that's sort of why I wanted to bring this up, because a lot of people are told they have this. Diverticulosis is, just imagine we're reviewing now, but just imagine the colon with just little out pouches. A little image there. There's your colon, and there's your little out pouches. And, those usually don't cause a problem until something happens. Those little out pouches can get taken over by bacteria and then inflamed and walled off, and that can cause diverticulitis. And that's really a complication of diverticulosis. And that's why it's important to kind of understand that, because everyone, I'm sure, has somebody, if not themselves, who's been told they got it. Right?
Yeah, pretty common.
I'm trying to think if it's anything, just it's unrelated, but just it is related, but it's a different subject. But just really a reminder to make sure everyone gets appropriate colon cancer screening, because symptoms can mimic each other. We call that, we have a term. It's really not very exciting. It's called change of bowel habits. If someone comes in and says, Doc, I used to have a BM every day, and now I go 3 times a day, or the opposite. I used to have a BM every day my whole life, and now I can't go every 3-4 days. That's a change of bowel habits, and that frequently is an indication for a colonoscopy, because you want to there's no substitute really for just kind of having a look at the colon to see what the problem is. A lot of people are getting alternatives to colon cancer screening these days, which is like a Cologuard or a FIT card, which is those are stool samples looking specifically for colon cancer. Very important to remember, those are not to work up symptoms. Symptoms need to merit their own workup. So if I have a patient who's never had colon cancer screening or is due for colon cancer screening, and they're telling me they're having some symptoms, they really should go have a full visualization of their colon.
It's not as bad as you think.
No. And a couple interesting things. The recommended age range for colon cancer screening for a long time was 50 to 75. But 2 things have happened. The lower age has been dropped down to 45. And the higher age, the CDC kind of issued a guideline that if someone's between 75 and 85, it's kind of case by case. If they where the benefit of testing might outweigh the risk, or the other way around. I'm still kind of absorbing that and deciding what to do with it, because it is true that the risk of complications from a colonoscopy kind of goes up with older patients too. The mucosa gets thinner. It's just a part of aging. So the possibility of having a perforation during a colonoscopy is kind of out there. So that's why it's case by case. So I'm still trying to kind of figure out how I'm going to adjust my recommendations to patients regarding that. The emphasis really, I still got plenty of patients who are between 45 and 75 who have not been screened, despite prodding. We got 1 minute to our break. The Cologuard, I order that for people. You got to fill out a form, you got to fax it. It has an expiration date, so people get it, and it must sit in there on their toilet for months, and eventually, if they do it, they might be expired, then they got to do it again, or I'll get a letter from the company saying it's now expired. So if your healthcare provider goes to the effort to arrange that for you, please follow through and do it. All
it's
right?
like 3 days a test, right?
No. It's really just kind of one sample, isn't it? They're confusing a couple different things, so maybe we'll review that after the break.
Thank you, Dr. Eric Stamberg and Robin Baker, for bringing us through this first segment of Medical Monday. You're listening to KCR, Kingston Community Radio, on AM 920 and 92.5 FM. My name is Dan Gatis, and it is 7:30 a.m., Monday, November 1st, 46 degrees here in Uptown Kingston. And we'll be right back after these messages.
As warm days slip away and the weather gets cooler, most of us will begin restarting our home heating systems. And that's when the threat of carbon monoxide poisoning is most critical. This potentially lethal hazard can occur with any furnace or boiler, so be sure to have yours professionally serviced regularly. Make sure chimneys and exhaust vents are clear, and use carbon monoxide detectors throughout your home. Central Hudson reminds you, your safety matters.
This fall, give us your best shot. Your photo of the Hudson Valley's autumn scenery could be worth $750. Enter Central Hudson's 9th annual Fall Foliage Contest today. If your photo gets the most likes on our Facebook page, you win. Deadline to enter is November 5th. For contest rules and information on how to submit your photo, go to Central Hudson's Facebook page or visit centralhudson.com.
Hi, this is Cameron Rylance from Kingston, and I support Kingston Community Radio because it's informative.
And you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, Monday, November 1st, and it's 46 degrees right now here in Uptown Kingston. And Central Hudson is sponsoring our upcoming segment of Medical Mondays. Partly cloudy skies today with a high of 57. That's it. Nice. Monday, November 1st, not a chance of rain. And Monday night, partly cloudy early, followed by cloudy skies overnight, a low of 39. Getting down there. Okay, and Tuesday, cloudy with a high of 53. And Tuesday night, some clouds early will give way to generally clear conditions overnight. Low of 32, there it is. And Wednesday, sunshine and some clouds, a high of 52. Wednesday night, partly cloudy skies, low near 30. That's it. We don't have a lot of rain. We did our due diligence with the rain. So, okay, let's get back to the on-air studio with Dr. Eric Stamberg and Robin Baker.
All right. Good morning. Welcome to the second half hour of this morning show. It looks like it's finally getting brighter out there.
Pitch dark.
Oh, it was so dark. You know, I was like walking into trees and stuff like that, just trying to get to my car.
Kids are waiting for the bus. It's pitch dark out.
Oh.
It is. Come on, where's that daylight saving? Where's that switch of time?
Yeah.
When does that happen?
Gotta wait a while.
I don't know. That's an interesting
Standard time?
discussion, too. Daylight savings. It's fall back. Yeah, it's probably coming up.
Right.
All right. Mm-hmm. All right. So my second subject of the morning that I wanted to talk about was not Lyme disease or tick-related infections, but tick bites. Why do I want to do that? Well, because, boy, do I get a lot of calls regarding this. And I worked at urgent care on Saturday, people coming into urgent care for this. I get portal messages from patients regarding tick bites. You know, so what are we going to do regarding that? You know, basically, so we're talking about tick bites. It's simply getting bit by a tick. I get bit by ticks occasionally. I live in the, kind of woods there, and I got a couple cats, and they go out, and they sometimes bring it in. I do treat them, in accordance with the recommendation of Dr. Bannister, my veterinarian. Little plug for Dr. Bannister. He had some funny jokes going on there. Robin, what? You ever drive by 32, Dr. Bannister's?
Yes.
What did the fish say when it swam into a wall?
I don't know. What did the fish say when it swam into a wall?
Damn. All right. I thought that was a funny joke. All right. Let's, if you were a fifth grader, you'd probably find that
That's
funny.
right. Yes.
Because you also get kind of a naughty word you're saying, too, which, anyway. Okay, so looks like daylight savings is November 7th, so that's
Next.
Sunday.
Yeah.
It's always on a Saturday into a Sunday, so it's coming up this weekend.
Yeah, Sunday 2 a.m. I'm getting all kinds of calls about getting
Daylight savings.
Yeah, clearing it up.
There you go. We can't wait. We wanted to come a week early. Well, anyway, so tick bite. So I get bit by ticks. You know what I do? Rob, what do you think I do when I get bit by a tick?
Take the tick out.
I take the tick off. That's right. And that's kind of about it.
There's a service now. You can send this tick off. I don't know where it goes, but they have these places
I
that
know.
will analyze the tick.
I know. I don't recommend that.
I hope, but people swear by this, Dr. Stamberg.
I don't think I don't think they're for a couple basic reasons. One is just because the tick tests positive for something doesn't mean you have it. And the other reason it's two other reasons. It's an expense. Okay, I don't know how expensive it is. It also takes time, so whatever maybe.
Conversely wise, though, if the tick tests negative, that was hard to say. If the tick tests negative, you could have something as well, right? Couldn't you?
Right. I am of the opinion that the tick bite that makes people sick is almost always the tick bite that did not get noticed. So I don't even find that a helpful question. And I usually don't even ask it to patients, did you get bit by a tick? Because remember, these ticks are small. But we're talking about the nymphs that are really not out now, which is one of the reasons I wanted to bring this subject up. But the nymphs are small, and they can attach to any part of your body and be attached for a while, which is when the longer they're attached is they more likely to transmit the illness.
Before you notice.
Yes. So all of this, there's a tick in my arm. I noticed it this morning. I pulled it off. That's not going to make you sick. I mean, highly unusual. It hasn't been there long enough. But, other parts of your body, the most common place is probably behind the knee. Because think about it, you're walking around with shorts on and the tick kind of crawls up. And who looks behind their knee? Who can look behind their knee? I've seen it other common places like in between toes. I've seen it in the groin. I know that's a little, off-putting, but, the tick, particularly in summertime, can crawl up through shorts, and a lot of people probably listening, squirming a little bit right now. I've seen it in armpits.
Dark, warm spots.
Yeah, for places that don't get checked normally. Armpits in women, under breasts, and imagine, hair.
Back of the neck.
Back of the neck, behind the ears. Anywhere in your hair. So really, the tick bite that makes you sick is probably the one that did not get noticed, and that's one of the reasons I wanted to bring this up, because I want to try to kind of get everyone to take a deep breath about the tick bites. Okay, so there was a study about 20 years ago. So that's ancient history by medical standards, that showed that if someone got a couple doses of doxycycline, and literally a couple doses, 2 doses of doxycycline after a tick bite, it would potentially prevent them from getting Lyme disease. But the study came with major caveats. And I'm also pulling this off of the CDC website. So the CDC has weighed in on this too. So the caveat number 1, the attached tick has to be identified as an adult or nymphal Ioxides scapularis tick, otherwise known as the deer tick. So you have to trust your tick identifying skills in order to really meet criteria to undergo tick bite prophylaxis. But what's hard about that? Well, first of all, the ticks do get engorged, so they're disgusting things. These bellies, get filled with kind of bluish blood, and they're just kind of rolling around, with their... And what also happens, and so if you really want to try to pull up a picture of this, of the deer tick on your computer or whatever, and see if this is what it looks like, it might already be distorted because it's kind of engorged. The other thing that can happen is when in the process of removing the tick, you kind of screw it up a little bit, and then so I find this challenging to identify the tick. That is and was something that the health department would do, help you identify ticks. I always kind of question the value of it for the reason I just said. I think the tick bite that gives you an illness, Lyme and other illnesses, is probably the one that did not get noticed. Okay, so that's number 1. The tick had to be identified as a deer tick. Sometimes I have a little tick lineup in my office. I have a little tick with the Groucho Marx glasses, and I asked the patient to point to the tick that was the one that bit them. Kind of like a CSI insect division.
You're being silly, but the ticks that come in the house, like on the cats and dogs, are big ticks. Like they're big.
Well, there's different species of ticks. So the wood tick, for example, and the dog tick, they're big. They're much bigger than the deer tick. And then the ticks themselves have 3 life cycles. Larvae, which are so small that probably don't get noticed. The nymphs, which are the ones that we're most worried about, they're usually out in the spring, although I think the ticks are a little confused about global warming as well and not quite obeying the pattern that they used to obey. There was a time where we would say, yes, the nymphs were out from mid-March to mid-July, but I think anytime it's over, 45 degrees or whatever, they might be active. And those are small, but one of the reasons why they're more likely to make you sick is they're small. That's the reason. You tend not to notice them. The adult ticks are big. They're more easily noticed. So see how simple it is? Anyway, so it has to be identified as a deer tick. The estimated time of attachment has to be 36 or greater hours based on the degree of tick engorgement with blood or likely time of exposure to tick. Well, if you just notice it, you don't really know what time it attached to you. But there should be some degree of engorgement. That bell, but I already kind of said then that makes it harder to identify the tick as a deer tick. You have to start the treatment within 72 hours of noticing the tick. And, it should be an area where Lyme disease is common. I find even this is changing. Remember, we're a more mobile society. The CDC specifically lists the following regions: Connecticut, Delaware, Washington, D.C., Maryland, Massachusetts, Maine, Minnesota, New Hampshire, New Jersey, New York, there we are, Pennsylvania, Rhode Island, Virginia, Vermont, Wisconsin, and West Virginia. So you're seeing all the Northeast, basically, a little bit of the Midwest, and that's kind of where you're seeing it. So that's my advice, okay? If you get a tick bite and it's not engorged, you should remove it. You could, look at some instructions online on the proper way to remove the tick, but the right way is to grab the tick by the head, not the body. Sometimes I find that helpful with a pair of tweezers. Make the skin with the other hand, make the skin a little more taut, and then with a motion perpendicular to the skin, kind of steady but firm traction to pull the tick up. If you jerk it, you might leave part of what I call tick remnants in the skin, and that's kind of its own discussion. There was a time, I remember back in the late 90s, where if someone came in and they said, I got bit by a tick, and you looked at it and you could kind of see, part of the tick still there. They even said to do something called a punch biopsy. Literally, numb up the patient, imagine like a hole punch and remove that whole skin. Well, that was kind of aggressive over-treatment. Ticks, it's like from a science fiction movie. The jaw of the tick leaves their body and goes into your body. So if you kind of jerk it off, well, that sounded really awkward over the air, didn't it? If you, with a jerking motion, pull it off,
it'll leave it in there.
Yeah, I can't believe I said
the jaw.
Yes.
Will be left in the patient.
Yes.
So my brother came by my house yesterday, and he had a tick, and he found he was doing yard work.
Right.
Everybody's cleaning up their leaves and everything. Right. So he had a tick in his chest. And
right there, we said, well, here it is?
Right here. Okay. Yeah, that's where he found it, like above his chest. And he asked his wife to, take it out. And she went with the tweezers, and she tried to take it out, and she left half of it in there. Yeah. So he did end up going to urgent care. Right. And he was like, I thought they'd have some, special tick removing technique or tool. He said, no, she was like, had a needle.
Yeah.
And I was like, yeah, that's how they're going to get it out of there, using a needle.
Right. We'll use a 16 or 18 gauge beveled needle. You know what a beveled needle is?
It's like slashed.
Kind of like a needle with kind of like a slice. And what you do, and it doesn't really hurt the patient that much, because you're really just going to the top. I think,
it didn't hurt. It was the idea of it.
You're just kind of trying to get underneath those remnants and kind of just removed
Flip them out. Yeah.
Yeah. And, well, was the,
It was successful, yes.
okay, the procedure was successful.
Right.
Successful.
But I did not ask him if he was given prophylaxis. This was something very common for people to call the doctor's office for.
Yeah.
And to not want an appointment, and to
Yeah.
not be seen, and to
Right.
not be evaluated.
Right.
But I had a tick, I had a bite, I want
Right.
2 doses of doxycycline.
Right. So I really think that it's, try to kind of remember that it's not really every tick bite, or not every
You
tick
need to
bite.
see every patient that this happens to.
No, but there's always this kind of gray area, and it can get a little awkward in the office setting. Where, first of all, it still is a prescription. It still is a medical evaluation and this decision-making process, and it should be done kind of the right way. And kind of just calling in these scripts.
Judiciously.
Yeah. The other argument is, what's the big deal, right? I mean, it's just 2 doses of doxycycline, not an expensive treatment. Even though doxycycline can really give someone a pretty bad sunburn. Obviously that's not an issue now, where the sun's barely rising. And I've really distracted my thought there.
Oh, I did?
Yeah.
Sorry.
Robin flicked something at me. All right. All right, so what was I saying?
You were saying that it's dark out.
Okay, never mind. All right, so look, it's one of those things that can be difficult in the office setting, and kind of make a little tension between the healthcare provider and the patient. It's happening a lot with portal messages.
Yeah, but so is this, you said the study, did it prove that people did not get Lyme disease if they had this
Yes.
2 doses of doxycycline?
Yes, it was a good study, and it did prove it. I don't think it's been replicated, however. It's kind of a hard study in a way. I don't know how they, you'd have to take people with tick bites,
Right, the control group.
control group, not treat them, and treat another group, and then follow them over a amount of time, a year or probably, I guess just a year, and see if there was a statistical difference in who got Lyme and who didn't. It does not extrapolate to other tick-related illnesses. And those are still out. I did have a patient recently.
Like babesiosis and ehrlichiosis.
Yep. So this tick bite prophylaxis has nothing to, no role with preventing those other illnesses. First of all, babesiosis is not treated with doxycycline. There's these other entities that are so closely related that unless you really look at a microbiologic level, I'm not even sure the difference, but they're ehrlichiosis and anaplasmosis. Very similar organisms cause identical symptoms, and the treatment's identical, which is doxycycline. But I just had a patient who got quite sick. He'd had his COVID booster, and then afterwards developed a very high fever, and really just all those systemic symptoms: fever, achiness, malaise, headache, and significant. Not a kvetchy patient by any means. And clearly, when he called, he was not feeling well. He had already gone to an urgent care that tested him for COVID, but didn't do the rest of an evaluation. See what I mean? That's sort of what I'm talking about.
Right.
That's kind of a different example, because this was someone who went, but really their tunnel vision was just really to rule out COVID. So, there was nothing else was done. And because of the degree of his symptoms and knowing the patient, I asked him to go to the emergency room, where his labs are markedly abnormal. One of the things these illnesses do, for example, is they make the platelets go low. Platelets make you clot. If you don't have platelets, you will bleed. Normal platelets, depending upon the lab, maybe 130 or greater, 150 or greater. His level was 30. Now, that's kind of the level below which you might actually have some bleeding. And then some other abnormalities were seen as blood work. And then so he was admitted, started on intravenous doxycycline. Testing for anaplasmosis came back positive. It's those 2 organisms are a little elusive. They're not always easy to.
2 organisms.
Anaplasmosis and ehrlichiosis. Matter of fact, there are docs out there who feel like it's not even worth trying to confirm the diagnosis, because by the time testing comes back, the patient's already being treated or not treated. I still do it for the sake of trying to, really just finalize a diagnosis. But plenty of times it comes back inconclusive, and the patient, was treated with doxy and seems to get better. But He did great. He did great. You know, he was in the hospital, I think, for 2 or 3 days. I saw him for his regular wellness visit. We also did follow up. I repeated his labs. They've normalized. But the point is that these illnesses are still out there.
Right, and they're presenting with COVID-type symptoms.
Right, and that kind of wanting to blame the booster. That was as Agatha Christie would say. I think it was Agatha Christie. Maybe it was Arthur Conan Doyle, but it was a red herring. It was a false clue. Therefore, I got the COVID booster, and the next day I'm sick. Therefore, it must have been the COVID booster. But in this case, it was not.
And so that's not Lyme disease.
No, but
that's very hard for people to understand. The difference between the tick-borne illnesses and that they're different.
Yes, there are other diseases that are transmitted by ticks. Some of them are quite scary and thankfully quite rare. So the one that's most commonly talked about is Lyme disease. And then there's 3 other entities that are common enough around here for me to routinely test for and be concerned about. Anaplasmosis and ehrlichiosis. We've talked about those 2. They're very similar to each other. They can make someone quite sick, and in certain cases even can be fatal. But in other cases, they can be mild and self-limited. In this patient's case, and once it's identified, the response to doxycycline is rather dramatic. And then there's something called babesiosis, which is a parasitic illness, which means that the organism is more than one cell. We don't need to get too technical there. Bacteria, by definition, are unicellular. It's a one-celled organism. So if something is more than one cell, it is not a bacteria. But that diagnosis can be a little more challenging. The treatment's a little more complicated. We use azithromycin, which is Zithromax. Interesting, right? And then something called atovaquone, which is in the family of anti-malarial medication. Problem with atovaquone is a couple things. First of all, it's expensive. Second of all, it's kind of a yellowish powder that can be, patients might have a hard time kind of taking. And third of all, and most frustratingly, is because it's expensive, coverage can be difficult. And insurance companies will frequently require a prior authorization, and that can take a couple days, if not a week. Meanwhile, we've diagnosed the patient. We need to start treating them. Very frustrating. So there are other tick-related illnesses that are worth mentioning. There's something called tick bite paralysis. Certain ticks will secrete a toxin that will paralyze you. It's rare, thankfully. And I remember the story, and I think it was a case at Vassar, but this was going back about 20 years, of someone who was admitted basically paralyzed. Horribly ill. And it really, was a couple days into the treatment before someone kind of looked at his head and says, "What's that?" and saw a tick attached to his scalp. Removed the tick, and within a couple hours to day, or a day or so, the patient started to get better. Tick bite paralysis. You might hear talk about the Powassan virus, which is tick-related transmission. I don't think that's transmitted by the ear tick. As a virus, a lot of viral illnesses we don't have specific treatments for. The treatment is to kind of just hope for the best. Support the patient, fluids, treat symptoms, and hope that they get better.
Powassan?
Yep, Powassan. And that may be becoming more common. Babesiosis, by the way, seems becoming more common as well. There's other illnesses people might have heard. Have you ever heard of Rocky Mountain spotted fever?
Yeah.
By the way, it's a little misnamed because it's not confined to the Rocky Mountain. In a way, Lyme disease is a little misnamed. It was first identified in Lyme, Connecticut, but as you can see, it's all over the place. That's a kind of a different tick species, and that's not that common. It can make the patient ill. I have not seen many cases in my career.
The health department, you have to report that to the health department.
Yeah, I think most of that's an interesting discussion too, just kind of reporting cases. I diagnosed Lyme. The health department, if I could offer a little editorial, it needs to modernize and make its reporting system a little more accessible and easy to do. It's still kind of a form that kind of takes some time. You have to complete the form, put all the information in, and then fax it over to the health department. So Lyme disease is phenomenally underreported. I have patients. The health department will get triggered if someone has blood work and the test is positive, and that will stimulate a request for a report. But there are a lot of people who come in with the rash of Lyme disease. Testing may or may not be done, and if it's not done, the case may not be reported.
Right. You don't need to do testing if you see that rash. For sure.
I don't think so. A couple things that I don't agree with, but you might hear doctors kind of recommend. If someone gets bit by a tick, it's sort of why we're talking about this, we should test you for Lyme 2 or 3 weeks later. I don't recommend that. I think you should monitor for signs and symptoms of Lyme and other illnesses, and if you have them, you should be properly evaluated. I don't necessarily recommend testing just because you got bit by a tick. All right, fine. If someone's recommending it, we could debate it. But I think the official recommendation is not to test just because someone had a tick bite. People, after they're treated for something, they will frequently ask if they could be tested to see if it went away. And that's not helpful either, because these are antibody tests, so antibodies can persist for the rest of your life. I find the hardest thing about Lyme disease is the fact that you can get it again, and it's hard to diagnose. If someone already has positive blood work and they come in and their symptoms are suspicious for Lyme, if they have the rash, okay, fine, that's an easy diagnosis. But if they have kind of other symptoms that may or may not be Lyme, the blood work, if it was positive in the past, it's going to be positive again. It's a tough call sometimes to decide if they have Lyme again or not. The entity known as chronic Lyme is very controversial. I seem to sense a little bit of a countercurrent that people are not going down that avenue as much as they used to a couple of years ago, which I think is good, because generally we feel that Lyme does not cause chronic symptoms. Fine. I always say to Robin and my patients, and when I work with students, don't put yourself in a corner. Don't say to a patient, absolutely not. So we kind of learn little tricks. It's kind of saying, well, it's highly unlikely. The current evidence does not really support that, but don't ever kind of say absolutely not, because it really puts yourself in a corner. So is it possible that there's some syndrome that's caused by Lyme disease that causes chronic symptoms? The answer is yes, it's possible. That being said, there are providers not far from here that will treat someone for chronic Lyme. The treatment is expensive, it's long, it has its own complications, too many antibiotics, for example. It's one of the things we started talking about earlier. And I don't know, they never seem to get better.
Not covered either.
Not covered, you're paying out of pocket, a lot of money. So just really, whenever I have a patient who kind of makes inclinations, seems to have an inclination to go down that avenue, I usually try to disavow them, but they pursue it sometimes. And they always, when I get the records, even when the tests are still negative, they still call it Lyme disease and treat it. So please consider that. We've had as guests on our show local infectious disease specialists, Dr. Tack, Dr. Cutler, Dr. Froud. This is what they do for a living, and they would really caution against that. Anyway, so tick bites, just to bring this back. Remember the caveats. It really should be attached to you for 36 hours or greater. Of course, the tick doesn't have a little stamp of arrival. Doesn't check in at the desk. When they attach to you. So sometimes you have to kind of just use a little bit of a gestalt about it. But the tick should be somewhat engorged, or else it hasn't been there long enough. You should have a good idea that it is a deer tick. I guess one little side point is doxycycline. For decades, we were told not to give doxycycline to pediatric patients, kids under 8, because it would, the reason?
No.
Stain their teeth. It would stain their teeth. Don't give it. It was actually probably bordering on malpractice to prescribe this medication. Well, that has been completely debunked, and the CDC really specifically even says the tick bite prophylaxis, if you're going to do it, is for adults or for children of any age are using doxycycline. So now habits die hard, okay? I mean, it's, something that I've been doing my whole career, not prescribing doxycycline to kids. All of a sudden, it's challenging to say, we're not going to do it now, because we also kind of, it's ingrained in how we do. So, but things change slowly. All right, let's go to our second break of the morning.
Perfect. Exactly 8 o'clock a.m. And many thanks to Dr. Eric Stamberg and Robin Baker for hosting this last portion of KCR. And KCR is Kingston Community Radio, WGHQ, AM 920 and 92.5 FM. It is 8 o'clock a.m. and it's Monday, November 1st. 48 degrees here in Uptown Kingston. This last portion of Kingston Community Radio was brought to you by Central Hudson. Thank you, Central Hudson. And we'll be right back after these messages.
We are Lions. We bring hope where it's needed. We are a global force for good. Support causes that matter. Change lives. Change communities. Change the world. We can do more together than we can alone. Join in. Experience the joy of serving. Be part of the movement. Give back. Let's unite the world for good. We are Lions. You can be too. Visit weserve.org.
Hi, we're the Goo Goo Dolls. We're fortunate that our daughters have what they need to grow and learn. But that isn't the case for nearly 13 million kids in the U.S. that struggle with hunger.
Childhood hunger is a heartbreaking reality that Feeding America is working to change. Each year, the Feeding America network of food banks rescues billions of pounds of good food that would have gone to waste and provides it to families and children in need.
You can help kids in need in your community by visiting feedingamerica.org.
Brought to you by Feeding America and the Ad Council.
Hi, this is Diane Eastwick from Athens, New York, and I support Kingston Community Radio, and so should you.
And we're back, and thank you for being with us here at KCR, Kingston Community Radio, AM 920, 92.5 FM, and streaming online at mykcr.org. This upcoming portion of Kingston Community Radio is brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building and maintenance and painting needs. Discover the difference of buying local. Sales ongoing at herzogs.com. And a little bit about the weather and forecast for the next 3 days. Partly cloudy skies today with a high of 57. Partly cloudy early, followed by cloudy skies overnight with a low of 39. And Tuesday, cloudy with a high of 53. It's going to be a chilly day. And Tuesday night, some clouds will give way to generally clear conditions overnight with a low of 32. Watch your gardens. Sunshine and some clouds on Wednesday with a high of 52, and partly cloudy skies Wednesday night with a low near 30. So that's the end of the growing season. Okay, let's get back to the on-air studio with Dr. Eric Stamberg and Robin Baker, and looks like we have a nice roster of birthdays today.
Yes, we do, actually. We have 3, I believe, if I counted them correctly. So, Robin, what does the winner of this morning's birthday contest, what is it?
A Boyce's Dairy Milk House cow pie. They're going to win one.
Your sentence structure was a little...
Have you ever had a Boyce's Dairy Milk House ice cream cake or a cow pie? It is seriously just the most delicious thing you'll ever have. So good.
Yeah, I know you and I love to go to Boyce's.
They're very special.
You and I love to go to Boyce's on a summer evening. Actually, we're kind of out of summer now, but it's really one of our favorite places there, kind of.
Get an ice cream cone, but the cake is so special. So my kids ask for it. That's what they. The
ice cream cake.
Yeah.
Yeah.
Okay.
Yeah, the cow pie is really special.
How many kids you have, Robin?
4. How many kids do you have?
3. A lot of kids.
Quite the progeny, huh?
Yeah.
Brady Bunch.
All right, Robin, we have 3 contestants. Here's the winner. Don't reveal the name of the winner yet.
Okay. This is very exciting.
And let's see. I'm confused about this one. Oh, there it is. Okay. There. That's one. Here, you go. There's two. So you do one, and then I'll do the other, and then you announce the winner.
Okay, November 1st, Monday. Happy birthday to Sylvia Van Dusen from your friends and family and all of those you take care of at the Senior Center. Oh, Sylvia.
There's also Sylvia. There's another.
Everybody loves you, Sylvia. And also happy birthday from the Cruz family and friends. Cruz is spelled Cruz. Happy birthday to Sylvia Van Duser.
And this is a lovely postcard, Lake George. Happy birthday to Rosella Crookston. Enjoy your day. Love your family.
And Monday, November 1st, please wish a happy birthday to Donald Genther. Donald, your friends from the Town of Ulster Senior Club are wishing you a very happy birthday today.
So hold on.
Who is the winner?
Getting all the bells out, huh?
Yep.
All
This
the
is
bells
very
and whistles.
exciting. Okay, are you ready? Drum roll, please. The winner of the famous cow pie at the Boyce's Dairy Milk House, 62 O'Neill Street in Kingston, is Rosella Crookston. Rosella, congratulations. And you can go by the Boyce's Dairy Milk House, 62 O'Neill Street, and claim your prize for today.
What am I going to do with the rest of the week? Because that is the high point.
It doesn't really get any better.
No, this
Doesn't get any better.
All right.
The mooing and the bell ringing. Our guests really enjoy that.
Yes.
Who'll be here next week?
It's a mystery guest. It's like the Masked Singer. We're going to have the masked guest.
Have you ever watched that show?
No, I've seen commercials for it. It seems fun, but amazingly stupid at the same time.
I think people really love
People
it.
do love it. It's a hit.
I haven't seen it either.
Especially like the Masked Doctor, you know.
The Masked Doctor.
Yeah. Remember the Unknown Comic?
Everyone's been wearing masks for a year and a half, so.
Right.
So,
Well,
speaking of, you worked at urgent care and at the hospital this weekend. You were very busy.
Well, the good news is the inpatient load of COVID seems to have lightened up, and I do think the surge of the Delta wave, that's kind of redundant, has tapered off, which is good news. But
You were at Northern Dutchess Hospital?
Yeah.
Yeah.
But by no means is it gone. And at urgent care, there were several positive cases as well. So we cannot...
we have to stay diligent. Right.
This is it. This is the battle. You know, we have to keep fighting until we defeat our opponent here. And how are we going to defeat our opponent?
Well, we have a tool, the vaccine.
Right.
And people are, I have many friends that are eligible and are very, very interested in receiving the booster, and they are actively pursuing that and getting that done. I had a couple of friends use the Best Buy site this past weekend. Ulster County is running a couple sites there. Well, they were encouraging people to make appointments.
Forest animals. Kids are coming to the forest.
They were encouraging people to make appointments, but then people who had appointments were showing up at the time of their appointment, but they were accepting all walk-ins as well. So if you had a 1:00 appointment, they were accepting all walk-ins who were coming in at 1:00 in your appointment time, but you weren't taken at your appointment time. There was like quite a wait. But I think just like when they initially started, distributing the vaccine, I think there's going to be like a little bit of a adjustment to giving the booster and adjusting to, and just keeping in mind, as we always say on this show, that the people who are manning those sites, those are volunteers, and everybody wants everything to go smoothly, but things don't always go so smoothly. So just try to stay patient, and I think that things will start going a little bit smoother as we, start giving the booster a little, more often.
Yeah, right.
Are you offering boosters at your office?
No, we are not. I'm not really part of the decision making. I know that we had some difficulty with just offering first doses. The problem that it's a vial of 10 doses.
Right.
And once you open that vial, you have to use them within so many hours, or else they were wasted. And we would do our best to book 10 people on and that day of the vaccine. That we were going to offer the vaccine. But frequently would have to dispose of a couple doses, and also, a couple reasons. We didn't fill 10 spots, and the other reason was people kind of make appointments and then wouldn't keep them. Maybe they eventually got the shot somewhere else. So I think that's a good caveat, too. If you do make the appointment but wind up getting the booster somewhere else, to make sure you just cancel the appointment.
Any controversy you can quell regarding, I've heard this, you have to wait 6 months from your second shot. If you had Pfizer or Moderna, your booster needs to be 6 months out. They were being very strict about that at this site, not giving it if it hasn't been 6 months. Right. And I had heard some controversy regarding that. Also about mixing the vaccines, that is quelled as well. That if you had Pfizer, it's okay to get the Moderna booster. Do you need a booster if you had the J&J? I mean, do you have that type of information?
I could try to look up. Patients ask me a lot of questions, and I jokingly say, I watch CNN just like you. I mean, right. It was constantly an evolving story. And I'd have to even check whether or not the booster for J&J was officially approved yet, but I think it was. I'll check that, but I think the 6-month guideline is out there. So yes, it has to be 6 months. Some evidence really said even a little bit later, made it a little more effective. I had one patient who said he read somewhere that it should be done at 8 months. I said, and he wants to wait. I said, okay, wait. It's okay. Let's see. Anyway, the booster gives protection to the already immunized individual. So it will prevent that individual from getting COVID, or it will prevent that individual from getting seriously ill from COVID. And remember, we're back to number one, prevent someone from getting COVID. The less COVID cases there are, the less it travels around. And that's the whole concept of herd immunity, trying to vaccinate as many people as possible. So the bigger problem continues to be people are not getting vaccinated. And I had a couple patients last week who were not, and it's frustrating for us. The reasons are just kind of nonsensical at worst, and just wrong.
I was reading cases of people who were sick with COVID who wanted alternative treatments that were not really proven or studied, and so they wanted like an unproven, unstudied treatment, but they didn't want to get the vaccine, which is obviously studied, obviously effective.
Right. The case that I had that I think we talked about a couple of weeks ago, but the woman in her late 60s did not want to get vaccinated, but asked me to prescribe her Ivermectin for prevention. And to make a long story short,
which is being studied, but is not approved or said to be effective.
Right. And I'm not even understanding even where. That would be relevant. Ivermectin is used for certain parasitic illnesses. It's used as a topical treatment for scabies and lice. Why it would be effective with this virus, I don't know.
But they're studying it.
And we went through this a year ago with hydroxychloroquine. And I remember sitting there going, what? Why would hydroxychloroquine is kind of like an anti-malarial medicine. It didn't really make sense. I said, maybe it's because it also has anti-inflammatory properties. Maybe that's why it works. But studies did not support it. Did not support the use of hydroxychloroquine.
You know what studies have supported?
Yes. You want to tell us?
The vaccine.
The vaccine, yes.
So anyway, we'll look into that, get a few more answers after the break regarding, the amount of time and whether or not you can or should be, like if you had Pfizer, should be getting a Pfizer booster?
The answer is yes, and I did just look it up. It is approved for J&J as well. But what's interesting is you can it turns out the Moderna is probably the best booster, and you can kind of mix and match. So if you had the J&J, you could and should get the Moderna booster. It's probably the best choice for you. The same thing if you got the Pfizer. So one thing I did want to, if we're on the subject of COVID, I wanted to talk about just variation by state of vaccinated rates, okay? And I wanted to look at our two biggest states. You know what our two biggest states by population are?
Population?
Yeah.
California.
Texas. So Texas has about 70% the population of California. But as of now, they almost... they're almost the same in the number of fatalities from COVID in their states. So it's about 72,000 for each state. Last time I checked, California had about 500 more cases, fatalities, than Texas. Remember, California was also kind of hit earlier before measures were in place. So if you just kind of look at population data, Texas should have 70% of the fatalities from...
just based on population.
Just based on population. Compared to California. You know what the third state in population is? I don't want to quiz you too much.
Is it New York?
It's Florida, but Florida and New York are very close to population. So now, as of now, Florida has more fatalities than New York. And remember, New York was also hit very early, before there was any treatment, before there was any vaccine, whatever.
Well, the airports are here.
What's that?
A lot of airports here.
A lot of traveling. And I just, to me, when you look at evidence of the effectiveness of public health measures and vaccine rates, amongst the population, you need to look no further than that. California did their thing, Texas did their thing, and Texas numbers are basically higher than California numbers when you look at
population.
Population, yeah. So that's just something to keep in mind. You understand that?
Yeah, we're with you.
All right.
Right, Dan?
I'm trying to...
You have a very sophisticated audience here. I don't know if you realized.
Just for comparison's sake, if you're looking at the vaccine rate for Texas, and the data I'm looking at is done by group. So we're looking at the 18 to 64 age range, because the elderly people have been pretty well vaccinated. They got hit pretty hard. They're pretty receptive to getting vaccines. So that age range, 18 to 64, basically the adults in Texas is 64%. In California, it's 70%. It doesn't sound like a big difference, but it is. These percentages have a very narrow window. Florida is 65%, almost identical to Texas. And New York is almost 76%. All right. So I just wanted to bring that up as kind of evidence that vaccination rates and public health measures, when you look at that data, do seem to work. The bigger problem is not so much the boosters. Remember, these are people that already have some degree of protection, and this is added protection for them. But really, it's just still people who will not get vaccinated. And it's very frustrating as a healthcare provider to kind of have this discussion. Someone will say, I've kind of had this discussion for a long time with the flu. People will say things to me like, well, I don't want a flu shot because I never had the flu before. To me, that's just very faulty thinking, So one of the patients from last week said to me that she had heard about all these horror stories about the vaccine, and she felt that the vaccine was more dangerous than the illness itself. And it's very hard to just even kind of counteract that, because it's so based in faulty knowledge and logic.
I have no response to that.
Have you heard individuals kind of, some of the reasons you've heard for people not getting vaccinated?
Even the most diehard person who initially said that they wouldn't get vaccinated, at least in my circle, they have changed their minds and gotten vaccinated. So I don't really hear any reasons anymore.
Yeah.
Even people who wanted to wait, which you could say, it's one of those things. You go first. Let's see how you do.
Everyone else go first.
Let's see how you do on it. But honestly, like, how many millions of people have gone first? And how much more evidence do you need?
Yeah.
So please get vaccinated.
Yeah. And, all right. I don't know. I don't want to spend the whole show on COVID. I think we touched on it again.
Yeah. So we started off talking about diverticulitis.
Right.
And
what?
Just things that happen in the colon, not necessarily diseases but
things that happen in the colon.
Well,
Chapter 1.
Right. This is interesting. And then we moved on to Lyme, and then we talked a little bit about COVID.
Yes.
So I was thinking about pain.
Pain.
I wanted to ask you a
topic.
question. So there's such a difference between muscular pain and like a nervous system type of pain.
That's right.
I'm currently having numbness in my toes, which we had a discussion, and you think that might be caused by a nerve being inflamed,
right,
causing pain. And
right.
How do you tell the difference between a muscular pain or pain that comes from the nervous system? And actually, one of the things that made me think of this is that ticks go on your body to where your nervous system doesn't feel as well. Like the tips of your fingers are very, right? You can very sensitive. But the middle of your back.
Well, ticks they secrete an anesthetic that numbs you, so you don't feel them bite you.
So it doesn't really kind of matter.
I think the reason you don't see them on your hands or whatever is because you look at your hands, but you don't necessarily look at your back, So I think that's probably a more likely explanation. There have been attempts to cultivate, this tick anesthetic and somehow, make it kind of medicinal for us. But
oh, interesting. I just remembering in school when they were talking about your nervous system and how sensitive we are. You can't feel a hair if there's a hair on your back.
Right.
But if there's a hair on your tongue,
right.
You feel it right away.
Your fingertips and your mouth. I mean, there are other areas that just have more nerve endings. But pain is very complicated, and I'm not even so sure we understand a lot of it. And why? First of all, you have to start with kind of saying, why do we have pain? It's kind of your body's way of telling you maybe something's wrong. But muscular pain is usually more of you can usually reproduce it. If someone says they have back pain, and first of all, you always want to get their story. So hey, first snowstorm of the year, I went out shoveling and went to lift up some snow and boom, something happened right here. That's acute inflammation. Usually, you just gently feel the area. We call that palpation. You gently palpate the area, and if it reproduces pain and the muscle is taut and spasm, that's a back spasm. That's muscular. Plus, if it's worsened by movement, my shoulder hurts, and when I lift it this way, it catches and hurts even more. That's also in the musculoskeletal system, not necessarily just muscular. Where neurologic pain is trickier, and it's weird. I had my own little health problem where some arthritis in my back and a pinched nerve going down my leg. And when I would walk, it would start to hurt. I had a very hard time even explaining the pain, other than the fact that it hurt. Robin saw me plenty of times have to limit my activities because of this pain. So, I remember, eventually I saw a specialist who gave me some shots in my back, and it's gone well. It's not perfect because the back still has arthritis, but that pain really has gone away, at least for the time being.
And the shots, what is the goal? Is that just reduce inflammation?
I just was a little, I remember saying to the doctor, I said, no wonder I can't get a good story out of my patients because I can't describe this pain either, It's hard to describe. It's a achy, it's a heaviness, so my problem was caused by arthritis. So your spinal cord travels down your vertebral column in a little tunnel, and at different levels you have the spinal nerves break off, every level basically, into a little opening. That's called a foramen. That's our term for an opening. And if that tunnel gets narrowed for whatever reason, the nerve will get pinched and cause these symptoms. Well, arthritis, in addition to bone wearing down, or arthritis also gets kind of jagged and things shift a little bit, so that that tunnel gets more narrowed. And that's so what he did was give me some injections to 2 areas of steroid that have calmed down the inflammation. Mm-hmm. And is it possible I'll have to have it done again? And I might. It's happened before.
Or that it would end up being surgical?
That would really be a last resort. If I had to just go through this, I don't know, every so often, I would choose that probably over having surgery.
Right, because at some point, I know like with hand injections and things, you've had as many injections as you can get, and you really have to resort to another treatment.
Right. Right. There's only so many times. It's case by case, and there are some rules. For example, in the tennis elbow, where you could be treated with an injection, but if you get too many injections, the area will just get thinned out by the injections and then tear completely, and then you'll have some degree of chronic elbow pain as a result of that. So you don't want that to happen.
So these nerves are everywhere, like not just in your back, but right? It could be like in your feet or.
You have I just went over this with my son Sam, who was studying for a test. You have the central nervous system and the peripheral nervous system. Pain can be mediated in different areas. For example, the headache, it has different causes. It could be kind of something external, like you hit your head, or it could be kind of like an internal combination of nerves and blood supply, kind of like what a migraine is. It's complicated. But anyway, so you always want to start with the interview of the patient and what's called a targeted examination of the patient. In your case, I think you might have what's called a neuroma. I think you might have the nerve that goes in between your foot bones. They are called metatarsals. And there's a nerve in between each of them, and that nerve can get irritated and then swell. That's a neuroma, and that's kind of that numbness, and when the tingling and the but plus the description of the pain, if it's burning and tingling, that's a little more neurologic than muscular, but it's complicated, and treatment it can be difficult. First of all, now that I had the treatment for my back, exercise is just so important. So much of my pain is exacerbated by kind of sitting. What do I do most of the day? I see patients, but I also kind of work on a computer, which makes me, rather hunched over. So the back is always in some degree of flexion, and that's worsen symptoms. So it's so important to do some extension exercises and just some walking, treadmill type stuff, or walk outside. Very important. So much pain is caused by, when we have the pain, we then maybe don't utilize it, and the pain kind of just exacerbates the pain. That's why if someone has like a back spasm, you really want 1, 2, maybe 3 days of immobility, but no more. You just got to get moving, even if it hurts. Moving is better than not moving, because it just gets worse.
What's happening in like a carpal tunnel type of pain?
Carpal tunnel is a specific condition where the median nerve, which is one of the nerves that goes to your hand, particularly controls these fingers. All right.
The thumb, the pointer, and the middle finger.
It goes. So this median nerve goes under a band of tissue at your wrist, which is called the carpus. So this band of tissue it makes a tunnel, and that tunnel can get narrowed for many different reasons. And if it gets narrowed, you'll have carpal tunnel syndrome.
So very indicative of like the tunnel in your spine.
Yeah.
Narrowing.
Yeah, except the tunnel in the spine is caused by bone, whereas this is more of a band of tissue. So it's not bony at all. It's a peripheral nerve, and then you'll get symptoms in the distribution of the median nerves. You'll get numbness, tingling, pain, weakness. The pain can be hard to describe. Sometimes the patient has what people call the flick test. Where they kind of literally, try to do this. Carpal tunnel is notoriously worse at night because when you sleep, you're kind of, you normally go into a little bit of a fetal position. So part of the treatment for carpal tunnel is to splint the wrist at night, so it stays in a neutral position all night. Driving can worsen it. I always wonder, because where this all came from. We're going to our break, but imagine an old-fashioned typewriter was a little more physiologic, whereas the computer keyboard was a little more flexed. And I always wonder, why don't we have computers with kind of that typewriter keyboard? Maybe carpal tunnel will be less. I never heard any. I don't know.
So carpal tunnel wasn't a big deal
right,
in the old manual typewriter days.
Right. It's just purely a theory, but I always wonder about that. Maybe let's all go into business together. All right, let's go to our break. Ari, go.
Okay, and thank you with being with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, WGHQ. Today is Medical Monday with Dr. Eric Stamberg and Robin Baker, and it's 50 degrees right now here in Uptown Kingston, and it's Monday, November 1st. Because the colors and quality of paint you choose matters, Herzog's Paint and Design Center, located in the Kingston Plaza, is there for you, offering the largest selection of Benjamin Moore paints and the area's most complete line of painting supplies. Herzog's Paint and Design Center also provides color samples from Benjamin Moore paints, including the eco-friendly Aura line. Color decorating consultants and expert interior designers are always there, ready to assist you in choosing the right colors. Visit Herzog's in the Kingston Plaza. We'll be right back after these messages.
Hi, I'm your host, Smokey Colbert, filling in for Smokey because after 75 years of...
Only you can prevent wildfires.
Turns out there's much more to say. Nearly 90% of wildfires are caused by us humans being careless, dumping our used barbecue coals willy-nilly. Guess the song was wrong. We did start the fire. That's why I respect Mother Nature and her trees, whether coniferous or new car scented. Brought to you by the U.S. Forest Service, your state forester, and the Ad Council.
Dance like a dad. It's a great way to make a moment with your kids.
First, I hold my hands out like they're on a steering wheel. Then I look over my shoulder. Next, I put it in reverse.
Visit fatherhood.gov. Brought to you by the U.S. Department of Health and Human Services and the Ad Council.
Okay, kids, Dad's gonna teach you how to dance. First, spread your feet apart. Then, pump your knee.
Dance like a dad. It's a great way to make a moment with your kids. Visit fatherhood.gov. Brought to you by the U.S. Department of Health and Human Services and the Ad Council.
Hi, my name is George Post from Ulster Park, New York, and I support Kingston Community Radio, and so should you. Where else can you speak to your local representatives on the air and have your questions answered? So thank you, and support KCR.
And we're back, and you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. The weather one more time for today and the next 2 days. Today, it's going to be pretty nice. Partly cloudy skies with a fair amount of sun, high of 57. And partly cloudy early, followed by cloudy skies overnight for tonight. Monday night with a low of 39. Tuesday, cloudy with a high of 53. And Tuesday night, some clouds early, giving way to generally clear conditions overnight with a low of 32. So that's the first 32 this year. I mean, at least after the summer. This fall, anyway. And Wednesday, sunshine and some clouds with a high of 52 on Wednesday during the day. And Wednesday night, partly cloudy skies with a low near 30. That means frost. And that means take care of our gardens. Okay, and this upcoming portion of Kingston Community Radio is brought to you by Ulster Savings Bank. It's 50 degrees right now here in Uptown Kingston, and it's Monday, November 1st, and you are listening to KCR, Kingston Community Radio, AM 920, 92.5 FM, and our call-in number is 331-9255. So let's get back to the on-air studio with Dr. Eric Stamberg and Robin Baker for this last portion of Medical Monday. Welcome back.
All right. Thank you. Welcome to the final
half hour
of this morning's show. And we were talking about pain.
Medical Mondays.
Yes, Medical Mondays. And we were talking about different types of pain. By the way, someone did call asking about if there's any special timing regarding your COVID booster shot versus your flu shot. When the COVID vaccine first came out, which is about 9 months ago now, maybe 11 months.
Yeah.
We didn't really know what to expect. So we did kind of say, don't get another vaccine within like 3 or 4 weeks of getting the COVID vaccine. But really, as time has gone on, that's not really a concern. So you don't have to stick to any guidelines regarding the timing of your COVID vaccine and the timing of your flu shot.
So you can potentially just get them both at the same time, if you're comfortable with that.
Yes.
I mean, if you're not comfortable getting 2 vaccines at once, space them out a couple weeks. Get your flu vaccine, wait 2 weeks, and then get your COVID booster, or vice versa.
And also remember a couple other vaccines that have been coming up. That's kind of one of our strategies, to
prevent people from getting sick.
Right. So, people
don't want to get shingles.
Shingles vaccine the coverage seems to be improving. The age is really about 50 and up. And I kind of for a long time, even though it was approved for 50 and up, I was really focusing on 60 and up. But now that the coverage seems to be loosening up, I'm encouraging people to get it 50 and up. Pneumonia or pneumococcal vaccinations are it's a good time to kind of see if you've had those and if you're a candidate for those.
Yeah, you can check your records and get scheduled.
Yeah, and I just looked up to confirm what we just said about the CDC. How long? The question is, how long do I need to wait after getting a flu vaccine or another vaccine before getting a COVID-19 vaccine? And the answer is, you can get a COVID-19 vaccine and other vaccines, including a flu vaccine, at the same visit. Experience with other vaccines has shown that the way our bodies develop protection, known as an immune response, and possible side effects after getting vaccinated are generally the same when given alone or with other vaccines. So, all right?
Okay.
So, I don't know. Maybe the county should have a, flu clinic right next to they've got to focus on.
Yeah.
I have to get my booster.
They got to get their feet under them. Yeah.
I'm not sure. I guess as a healthcare worker, I'm eligible.
Booster is such a funny word.
All right, pain. We were talking about carpal tunnel. It's a specific syndrome and then we were kind of theorizing that maybe an old-fashioned typewriter's protected against carpal tunnel. Because think of all the people who typed through college and whatever, and secretaries in the 40s and 50s.
Yes, I have. My mom was a 120 word per minute, executive secretary, and she never complained about carpal tunnel. It's interesting.
Just complain in silence, or was it not happening?
No, she kept being able to type like that even for my papers and stuff like that sometimes.
Oh,
but yes, she'd do it, and no, never. Never anything about her hands.
Young people wouldn't remember, but using an old-fashioned typewriter took a lot more effort. Like, it was harder to push the keys down, and kind of like working out, maybe like going to the finger gym.
Finger gym? So, the normal position for the wrist is, we call it a soda can or beer can position. So, think of a spoon, and that's called extension of the wrist. So, I guess our idea is that if you're typing, your wrists are in some degree of extension, whereas if you're on a flat computer type, you're kind of flatter. Maybe that's bringing it out more. I don't know. A couple of risk factors for that. Diabetes is a biggie. Diabetes just kind of causes things to kind of swell and kind of get bigger.
Risk factors?
Yes, a couple of risk factors. Very funny, Robin. We had more questions about pain. So it's interesting with the treatment for pain. We have a couple options, anti-inflammatories and first of all, acetaminophen, doesn't really get enough credit. It can be very effective for all types of pain. Acetaminophen and then
which is Tylenol.
And then these called NSAIDs, which includes ibuprofen. They work on things called prostaglandins, which have a role in mediating pain. But I find that those are really more helpful with musculoskeletal pain. And they can be very effective. A pulled muscle, a stiff muscle.
Because it really reduces the inflammation.
Yeah. Although they can be effective with headache. It's just that there's certain types of pain that are more neurologic. like the pinched nerve I was talking about. And I don't know. I'm not. Sometimes you have to go on a medication that might help with that. One that's used commonly is called Gabapentin, which kind of stops the nerve from firing. Is just the simplest way to think about it. A lot of ads run for a medication called Lyrica, which is kind of like a cousin to Gabapentin. It's a good medicine. I find a lot of side effects with that, a lot of sedation. Whenever you have a neurologic medicine, works on the nerves, you're going to potentially have neurologic side effects. Sedation is a biggie. Opioids this is one of the reasons that led us down the avenue of prescribing opioids and too many opioids. People had pain. They had a lot of pain. And we wanted to treat their pain. One of the primary roles of a physician is to try to relieve suffering. And then we had external pressure to treat pain. There was, for a while, called the fifth vital sign, which is always kind of misnamed. And we knew that from the beginning. A sign is different than a symptom. See, a symptom is what a patient tells you. I have a headache. A sign is something that's a little more objective. Blood pressure is a sign. Temperature is a sign. Pulse rate. So when they started to call pain the fifth vital sign, they already were getting into kind of uncharted territory because it's not subjective. It's not objective. It is subjective. They get a little smiley face thing. You're supposed to circle it. So we started to get external pressure to treat the pain, with the subtext being that somehow we were not doing our job if we were not treating pain adequately. And it's very, this led down the road of opioids being prescribed more generously, and then down the road of people with more opioid problems. I think we kind of made the U-turn in some respects a little too dramatically. People kind of cut off abruptly from the medication that they received for a long time. On the other hand, though, I have some patients who were very slowly and gently tapering down onto a more, I don't know if they'll ever get off of the medicine, but they'll be on a more acceptable dose, which will not put them at risk.
Right. You're not coming up with these levels, though, are you?
No, the levels, actually, I guess they probably come from the CDC. They use something called the MME, which is the morphine milligram equivalent. So basically, you're taking any opioid medication, converting it to an equivalent dose of morphine. And generally, you want the MME to be less than 90. I did read 100 once, but the lower the better. So that's, and then I find that very helpful for patients where, to say this is the recommendation and this is where you are and we're going to work you down. And it can be complicated, a little resistance sometimes, but. A couple patients, been quite successful, and then doses come down, and then they're feeling actually a little better. One of the weird things about opioids is they can actually worsen pain. You can get what's called opioid-induced hyperalgesia. Things hurt more because it kind of just affects the way your nerves are wired. It's almost like a rebound pain. So that's the treatment for that is to ironically taper off the opioids.
How would you, like in layman's terms, describe a rebound pain? Is that like if you do sit-ups and then you're done doing sit-ups and then like you finish doing sit-ups and then your stomach hurts?
No. I think that's just more of a muscular pain from fatigue and also that pain will go away as you get in better shape, right?
So what do you mean about rebound pain?
Rebound means like you're suppressing something. For example, anti-inflammatories. People take anti-inflammatories for their headaches. People have headaches a lot. Some people have headaches every day. You know what that's called? Chronic daily headache.
Oh.
But to different degrees, though, it can be in the migraine family, and they'll take ibuprofen regularly. But then they'll cause their own problem if you don't take your ibuprofen, you'll get rebound headaches. So imagine you're trying to suppress some symptoms, and then when the medication wears off, the body kind of says, "Oh yeah," and secretes the chemicals that cause the pain to begin with. That's kind of what rebound headaches are. So yes, part of the problem with long-term anti-inflammatories is it can cause rebound headaches. So we're just the idea of pain in general, trying to minimize the use of opioids. I will not jump on a bandwagon that says never, because there are times where it's okay, and it is the right thing to do. You have to, look at the case and the big picture. For example, if I have someone who's, has a bad arthritis pain, but they have a reason not to take NSAIDs, we call that a contraindication. To prescribe something, it means it's indicated. To not prescribe, it means it's contraindicated.
What's an NSAID?
NSAID is like an ibuprofen or a naproxen, Aleve, Advil, Motrin. For example, these medicines can cause ulcers in the stomach. So someone might have a history of ulcers, in which case it's not a right choice for them. They can also affect kidney function. So someone with some kidney problems, it also may not be the right choice for them. There's a couple other reasons. So there are times where, to relieve suffering, it might be the right choice for the patient, but in a very controlled setting, to understand that this is a treatment that needs to be closely monitored and supervised. I have a couple patients, they are elderly, they don't tolerate NSAIDs, they have pain that really affects their quality of life. They're on a low dose of the medicine. There's no evidence of any escalating or what I call a dysfunctional pattern with the medication. I see them, they're tolerating the medication. In the big picture, it's kind of the right choice for them right now. So I wouldn't be so quick to cross it off the list completely. They let that pendulum swing so far in the other direction.
Right.
But yes, we did have a couple of decades of very permissive opioid prescribing, and it's very easy to point fingers. It really is a systemic breakdown. That came from many different directions. It came from patients that really maybe had an unrealistic explanation that they were going to be taken out of pain completely. It came from external pressures, some of which were promoted by the pharmaceutical industry. To treat pain. Again, we were kind of labeled maybe that we were not doing our job if we did not treat pain correctly. So it's complicated. So it's kind of wrong to just kind of simplify the problem, but I do read stories of cases that are clearly egregious. Stories like in Florida where what they would call pain mills. People really be given a lot of medication regularly. Remember, medicine is a volume-based business. I get rewarded by volume. I get rewarded by doing more, not by necessarily doing better. So, if a busy day is seeing many patients for quick refills of medication, there was rewards to that. So we're trying to adjust that formula now and say medicine really should be more about the quality of the care, not the quantity of the care. But it's a tough undertaking because that's hard. It's hard to measure quality. We've talked about that other mornings.
Yeah.
You agree with that?
Yeah, I totally agree with that.
Anyway, so as far as pain goes, you want to, I always just start with a good history and physical. I'll say that again and again. Tell your story. Sometimes I refer a patient to a neurologist, or if I think it's more of a musculoskeletal and I can't quite figure it out, I might refer to a rheumatologist. If it's something specific, like a knee that hurts, that's an orthopedic problem. And when a patient sees a specialist, and then I'll see the patient again, I'll ask for feedback about how the visit goes. And generally I want to know that the patient had a nice consultation. That wasn't rushed or hurried, because it's the reason I referred the patients because they got something complicated that needs the input of a specialist.
Right. You always say when you refer to a specialist, you want one of two things. You want the specialist to either, number one, agree with you.
Yes.
Or number two, disagree with you.
Yes, that's right. I guess there is a third reason, which is to just help with a diagnosis that I have not been able to make on my own. But in a way, that's kind of agree.
It's right. It's a agree or disagree.
Yeah. I think you have migraine headaches, but they're a little unusual. And we've tried some basic things, and you're not responding as well as I would like. So I think it is reasonable and time to have you seen by a neurologist who will either agree with my diagnosis and my treatment, or not so much disagree, but try different things or run some more tests, whatever.
Okay. Are you seeing a lot of I'm going to segue to another topic.
Okay.
Are you seeing a lot of allergies this year?
Yes.
So, and allergies, like they present as a cold, don't they?
They can mimic a cold, and it's not that easy. I always say to patients, look, a cold is an illness. We've all had cold. Do you feel sick? I mean, allergies can be so bad that the patient feels sick.
Yeah, that's what I
cause
mean.
A little bit of a fever.
Yeah.
But generally, this is more of a chronic pattern to the allergies, whereas the cold kind of lasts 3 to 7 days. You start to, cold, you start to feel a little achy, a little headachy, your throat's a little scratchy. The next day, you start to get, nasal congestion, and, over 3 days, your symptoms just kind of worsen. And then over anywhere from 5 to 7 days, your symptoms will kind of get better.
And you kind of have to be careful with allergy medicine, right? I mean, that can really make you tired. And
antihistamines are very sedating. Newer antihistamines are okay, actually. For years we kind of just had Benadryl. And Benadryl, makes people pretty dopey. Makes you pretty tired. Dramamine is also an older antihistamine. Again, that's kind of marketing in a way. Benadryl was marketed towards allergy, whereas Dramamine was marketed towards motion sickness. They're both kind of antihistamines with very similar properties. Just kind of shows you how the marketing really, and the fact that we use the brand name synonymously with the generic name. We don't say diphenhydramine. We say take a Benadryl.
Or Sudafed.
What's that?
Or Sudafed.
Sudafed is for pseudoephedrine, yeah. Though the decongestants are tricky because they can be stimulating to the heart, and they can raise blood pressure. So someone who has a history of AFib, for example, really should avoid decongestants. It can make it challenging to treat symptoms. The cornerstone treatment for sinus allergies is a nasal steroid. Fluticasone, which is otherwise Flonase. There's a bunch of, they're all over the counter now. I have mixed feelings about that when something goes over the counter. Actually, I don't have mixed feelings. I kind of don't like it. I think these are medications. I think these are complicated. And I think that they need to be supervised.
Right. Does somebody who has some heart issue or AFib or high blood pressure, do they know that taking Sudafed can be a contraindicated medication? I mean,
they can read the label, but labels are long and not always clear. There might be some warnings right here on this cough drops that we have here. Warnings, sore throat warning. Ask a doctor if you have, things like that. By the way, part of the reason they have those warnings is because they don't want people to have something seriously wrong and that they're just kind of treating over the counter forever.
Right. You're on the radio, so nobody realizes that you're looking at, you have cough drops. They're like the Halls brand. So you're just reading the warning on the back of the Halls cough drops.
Actually, I didn't want these. I wanted just some Smith Brothers or Ludens or something. I couldn't find them.
Why? What's the difference between Halls and Smith Brothers or Ludens? Or just because you like the old days?
Menthol has a little kind of soothing property, but it's very drying.
Or you just long for the old days, where the old time cough?
Yeah, I think even a Lifesaver, just any remember we called them granny candies? They sell them over at the Rosendale Market there. Those kind of cough drops, or just those what would you call those? The
lozenges?
The powdered candies that your grandma would have in a tin.
Oh, the ones that look like they have powdered sugar on them. Oh, I'm going to be a grandma. I got to get some of those candies.
It's part of the requirement.
I mean, someday.
You're on your way. The sweater, little. Anyway, so we were talking about over-the-counter medications and how, you have to understand there's still medications, the industry push to get something over the counter is tremendous, and sales do go up. So there's an incentive for companies to make these products over the counter. I don't know. If some of these things were grandfathered in, aspirin, Tylenol, you could fatally overdose in Tylenol, By the way, there's an intravenous form of Tylenol that's branded Ofermev. And it's 975 milligrams, so that's actually the equivalent of 3 tablets of Tylenol. But it's amazingly effective. When this first kind of came out, I was very cynical that this would not be a good treatment. But this is a very good treatment in the acute setting. It's intravenous, and it's a good option for...
used in the hospital.
Yeah, kidney stones, post-operative pain, unless there's a reason not to take acetaminophen, it's a very safe medication.
Wow, that's great.
But
you wouldn't be given, that unless you were like in an acute situation in the hospital.
Right, but it's a good alternative to an opioid medication, for example. So, for example, kidney stones are phenomenally painful. I've never had one, thankfully. Women will compare it to childbirth and sometimes say that having the baby was less painful. So men will say, no way. And then wives will get very angry at them.
So we'll segue from allergies to kidney stones. So what's happening when there's a kidney stone passing?
A lot. The body's amazing, too. So the things that have been innervated with tons of nerves and other parts of the body that have not received a lot of nerves. It's really interesting. For example, you could even probably see clips of this on YouTube. They're weird things. People having kind of brain surgery where they're kind of kept awake for various reasons. And because there's not much pain in certain parts of that, that they can have it while awake. Whereas the capsule around the kidney is very painful. It has a lot of nerve endings there. And also the whole pathway that a kidney stone would take down out of the kidney into what's called the ureter, connects it down to the bladder and then out. The whole thing just has a lot of nerves. And, a stone is kind of jagged, and it's irritating.
So how do you get a stone in your kidney?
Oh, that's a big topic.
Is it?
Yes, it really many different factors. Age factors, gender factors, genetic factors.
And so it's a calcification, or?
There's different types of stones, but around 80 to 85% are calcium related. There's around 15% that are uric acid stones. Let me try to remember. Around 70 to 80 are calcium. Around 10 to 15 are uric acid. Around 10 to 15 are they're linked to people who have a lot of kidney infections. They'll get a certain type of stone as well. And then there's a rare type of stone called a cystine cell. I do have a patient who gets those though, and he has to take a special medication for them. But kidney stones, look, they're rough and they hurt. So what do they usually do? The pain will be one side or the other. If it's in the middle of your back, it's probably not a kidney stone. That's probably more of a problem with your spine. One side or the other, sudden onset. Really kind of hits you. Because the stone literally kind of can be there for a long time until it moves for whatever reason, and can stimulate the pain. You might have blood in your urine that you notice. You might not, but if you come to be evaluated, we'll check a urine, and there should be some blood in that urine. And that's one of the cardinal symptoms of the kidney stone. It's a big topic. Maybe that is. I'm trying to hunt down a urologist, and maybe I'll follow up this week and see if we can get him on the show and talk about
some more of those type of issues.
Yeah, because so very, very painful, very important. A lot of times they don't have to be admitted, but they do need an emergency room visit to treat. A lot of hydration. If you have kidney stones, very important to make sure you drink enough fluid every day of your life. That's one thing we agree on.
And it's not surgical always, right?
No. There are stones that have to be retrieved. There are stones that can be broken up with sound. That's pretty interesting stuff. That's called lithotripsy. Anyway, I think we're done with this morning's show. Robin and I will be back next week. I want to thank Dan, as always, and the Maxwell family. They're doing their Christmas fund, so please give to the station to keep shows going. Thank you for listening.
The Radiothon is November 4th.
It's the Happy Christmas Fund.
Yes.
Yes, usually our Radiothon is in the spring, just to keep them separate. And the Happy Christmas Fund is, of course, for children's toys and family toys and things like that for
What's
Christmas.
going on with the 4th?
Yeah, that's the Happy Christmas Fund.
Yes, that's the Happy Christmas Fund. Happens at Boy's Dairy Milk House.
Of course.
Yay.
Yes, absolutely.
All right, so give if you can.
Thank you, folks. And thank you, Robin Baker and Eric Stamberg, for all of your service in the medical fields. And thank you for donating your time today for Medical Monday. And thank you, listeners, for being with us and participating in Kingston Community Radio. And you have been listening to KCR AM 920 and 92.5 FM WGHQ and our live streaming on mykcr.org. This last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. We now return you to Magic 92.5.